I'm joined with my colleagues who are super specialists in various subspecialties in orthopedics. From my right side, Dr. Harshad Jawalkar is a shoulder and upper limb surgeon. Dr. Kalyan Verma is an orthopedic spine surgeon. Dr. Rajesh Racha is a lower limb orthoplasty, sports injuries and foot and ankle surgeon. And Dr. Avinash is a hand and wrist surgeon. So today's topic is the role of PRP in treatment of orthopedic conditions. In the recent past, we have seen a dramatic increase in the use of PRP in the treatment of orthopedic conditions. However, many of our patients and their families come to us and ask, is PRP really useful in the treatment of our orthopedic conditions? PRP or platelet-rich plasma is nothing but when we take a sample of blood and separate the platelets, which is a component of blood, and increase its concentration more than 5 times. That is what is exactly PRP. I would ask Dr. Rajesh, can you please explain how does the PRP supposed to really work?
How it's supposed to act is it has to decrease the inflammation by reducing the inflammation, number one, and number two, by proliferation of the cells, and number three, by increasing the blood supply to that area, and also by remodeling the cells. Thereby, it has to form new cells and help in healing as well as increasing the cells and healing of that particular area of interest. But one has to understand this is not a stem cell. So that has to be very clear. The PRP is completely different from a stem cell, where stem cells are, they renew themselves. They are undifferentiated cells where they differentiate into new cells, but the PRP is not doing that. So there's always a myth in the society that most of the patients come and ask us, oh, we are injecting stem cells, right? No, these are not stem cells. So stem cells have a different role. They renew cells and they form they have potential to form new cells. Here we are not doing that. Here we are injecting into an area of interest where it is going to proliferate, decrease inflammation, and remodel by forming new cells because of the presence of some growth factors and bioactive substances within these platelet-rich plasma, which are helping in the regeneration of or healing the damaged tissue.
So in short, platelet-rich plasma is a part of the whole blood,
yes,
where you're separating the platelets, whereas stem cells are completely different.
Correct.
The source of the stem cells are either you can get it from bone marrow, you can get it from fat,
embryonic cells.
Embryonic cells like from umbilical cord.
Correct.
So there should be no confusion between the PRP and the stem cells. So they are completely different. Harshad, PRP has been used for so many days and it's evolved. Just give a simple example of how is it done? What is the process involved in doing it?
Thank you, Dr. Srinivas, for the introduction. PRP is quite commonly done. It is done as a daycare procedure. That means the patient can go back home the same day of the procedure. It's quite a straightforward procedure. Like you mentioned, the patient's blood is drawn. The patient's own blood is drawn. Just like you'd give blood samples for tests, similarly, blood is drawn. The quantity depends on the site of the injection. So for example, for elbows, we need a very, very small amount. And for larger joints, we need a larger amount of blood. So it can vary from anywhere from 30 to 120 milliliters of blood. And the next step would be to separate the blood into its components. So this is done by rotating them in a centrifuge. So basically, at high speed, the liquid component, the plasma separates, and all the solid components, the red blood cells, white blood cells, and the platelets are separated in a test tube. Then we separate them and take out the PRP, that is the platelet-rich plasma, by discarding the red cells and the white blood cells. There are different types of doing it, but broadly speaking, what we commonly use is the pure platelet-rich plasma. This is injected. The whole process takes around 20 minutes to half an hour for us to do the centrifugation. And then the platelet-rich plasma is injected wherever it is needed. The accuracy of the injection can be improved by ultrasound guidance. So again, it is an outpatient procedure. By use of a simple ultrasound, we can target the location where the injection needs to be given. And local anesthesia can be given to minimize the pain. Anyway, the pain is not much. It is, you'll feel the same pain when you're being poked by a needle. That's about it. So, and the patient can be out of the hospital in, say, 20 minutes to half an hour after the injection.
So it's a straightforward procedure. To sum it up, we draw the blood from the patient at the 30 to 120 ml, separate or filter out the platelets, and inject them back into the patient or the condition wherever it is.
Absolutely.
So, Kalyan, what is the confusion among even the doctors on how to use this PRP?
Thank you for the introduction. So basically the confusion lies because there is no standardization on how it is prepared. Now we know that the blood is drawn, it is centrifuged and it is used. But how much blood is drawn, what centrifugal force is used, how much time is it used, and what temperature is it used. All these factors will change the way the PRP may work, right? So there is no standardization on the time, the force and the temperature which are involved. Also the number of times. There are two predominant ways people do PRPs. One is a one-time centrifugation, one is a two-time centrifugation. Again, there is no standardization on this. Again, one more confusion is on the type of PRP. Now, the main components which are there in PRP are platelets, basically the blood cells which help in clotting, and they are the main source of these growth factors or whatever regenerative properties are expected of these things. Then there is fibrin or more or less a protein in the blood, and there are leukocytes. These three components will decide the type of PRP. It can be a leukocyte-rich PRP, it can be a leukocyte-poor PRP, it can be a pure platelet-rich plasma. All these factors lead to a lot of confusion because each one uses their own way to deal with degenerative conditions, and the results may vary based on the type of method followed. So I think that is the confusion.
Completely agree. If you go back into history when the PRP was started, it was started somewhere in 90s, and we are in 2025 now. It's almost 35 years where the PRP has been in practice. However, still there is no consensus on how the PRP or what should it constitute for a particular condition or any condition. That confusion is still persistent, and that is the reason why probably the results are very varied. So again, the other confusion is not only the components in the PRP, how many injections are to be given. What is the evidence, Avinash?
Thank you, sir. Thank you for the introduction. So initially it started with a single injection. People used to give single injection at the place where the patient had the symptoms, and then over a period of time it has increased to then multiple injections. They have started giving multiple injections now, and up to 3 injections to 7 injections have been described in the literature. But again, the results are not conclusive. People have come up with super PRPs now with high concentration of concentration of platelets in it, but still the evidence is inconclusive.
Yeah, I mean, that is where is the issue. So when you look at how it is started, initially single injection, and there were studies which compared single injection with 2 injections or 2 with 3 injections, and now we are talking about 4 more or more. So that is still existing problem. So when it comes to orthopedic conditions, what we treat, we can broadly classify them into trauma or injuries. The second thing is degenerative conditions like osteoarthritis, etc. Or it could be because of mechanical problems like stiffness in the joints or instability in the joints, or it can be tumors or infection. These are the 5 broad categories, right? So when you think about the trauma, it has been used in treating fractures or sports injuries, and there is not a conclusive evidence yet. So, how many of you actually use in any of the trauma patients? Out of 5 of us, none of us use PRP in trauma. Second thing, infections, there is no question, you don't want to inject anything into the infection, you want to treat with appropriately. Okay. Tumors, again, that is no way. Mechanical problems, if I am going to inject a steroid, PRP or any other injection into a stiff joint, is it going to get better? No, it won't. Unstable joint, it won't get better. So, mechanical conditions are also out of question. So, the only thing left out is the degenerative conditions. This is where we can actually explore the role of PRP. And in some injuries, like in sports injuries, there is some evidence. So, in inflammatory conditions also it has been explored, but still we don't have evidence. So, Rajesh, in knee arthritis, there is so much of controversy going on about PRP, super PRP, etc. Please give a snippet on what's the evidence.
Yeah, so when it comes to PRP in musculoskeletal conditions, then the most often discussed topic is the PRP injection in the knee, especially in the osteoarthritis of the knee. Now, let me give an example. Okay, so a patient, relatively moderately built patient, comes with a deformity, and while walking, the patient says he's in pain, and also his knee is buckling. Okay, and then that patient comes with pain, and you get an X-ray, and then see there is some arthritis in the knee. Do you think the PRP is going to help? So here we have a mechanical problem. Though the patient has some pain, the patient has got mechanical problem. He's tripping, and then there is some deformity. So how would one expect an injection to help in such situation? You know, so he has got degenerative changes. Yes, by all means. So theoretically, the PRP injection should help. But the most of the time in an osteoarthritic individual, this is a scenario. So in early arthritis, like say in a stage 1 or stage 2 arthritis, where there's not much of a deformity and there is no instability in the knee, then one would say, or the literature says, that it might help. That too, this literature I'm talking about a few years back literature, but the current evidence will come into that whether it will work or not. But initially there was some evidence saying that in the early stages of arthritis it might help. But in such stages, in early stages, whether you don't give PRP also, the result might be the same. If you put him on proper exercise regime and the activity modification, that itself is alone might improve the symptoms rather than actually injecting PRP. So we'll discuss in detail about the nuances and the current evidence as to whether there is any role of PRP in osteoarthritis knee.
Yeah, I mean, if you look at the old literature, yes, still there wasn't any clarity. And the PRP, if you look at how it is very much used in US. Even the Journal of Bone and Joint Diseases, the editorial last month has said there is no role of PRP in osteoarthritis of the knee. That's a conclusive kind of a statement they have given. And the other trial which has looked at the osteoarthritis and treatment options, they injected saline in one joint and PRP in one joint, the Restore trial done in Australia. And they also clearly said that there is no difference in the outcome. In fact, they also looked at the volume of the cartilage in the joint. Yes. That is a very interesting thing. And even there is no change, no difference in the volume of the cartilage after injecting the PRP. So that's where we stand with the osteoarthritis.
That's right, that the Restore trial from Australia, it's one of the bigger trial, so in which the placebo versus PRP injection in osteoarthritis knee doesn't make any difference. Including the, as you said, the volume of the cartilage was also looked into. There might be some relief initially, but if you look at it in the long term, neither the chance of going into totally replacement has changed, nor the volume has changed. and the results after more than 6 months are more or less the same when compared to placebo injection.
Kalyan, back pain is very, very common. And how do you go about diagnosing your back pain problems, and what is the role of PRP in them?
So yeah, when we talk about use of PRP in spine, we should also understand in what condition it is used, what stage of his spine when it is used, right? Broadly, to understand in simple terms, you understand spine, you have two bones in between which lies the disc. Basically, the disc is a gel-like structure. It is a soft material which moves when your spine moves, and that acts as a shock absorber, similar to the shock absorber in your car or your vehicle, right? So basically, when your spine is loaded with axial loads or compressive loads, this disc will disseminate it so that your spine will not take the actual load, right? So what happens with your aging process, this gel-like thing is going to get harder. When it gets harder, what happens? Your front column, if you divide your spine, it has 3 columns, but now to understand it simply, we can divide it into the column in the front, the column in the back. The disc lies in the front column. So now your disc is harder. It is not able to take the load. So the majority of the load falls on the back column. That is where your joints lie, the joint which holds your spine together. So too much of load in those joints is going to lead into arthritis, which is facet joint arthritis, or basically a degenerative arthritis of your spine. This is how the degenerative process works in the spine. Now, which stage of your spine do you have your pain? You can have pain at all these points in the spine. When your disc gets harder, you can have a degenerative discogenic pain. When your facet joints get loaded, you can have a facetogenic pain. And when your facets get loaded, it can cause some instability. That is more movement than what is normal. It can cause an instability sort of pain. And the last stage usually is a stage of settlement. That is, once it becomes unstable, slowly your body adjusts itself and it settles. It's called a stage of stability, right? So you use it in a stage where it is almost going to the stage of stability. Then even if you do not do anything, it is going to get better, right? So particularly you should understand how to diagnose at what stage the patient is in and what sort of pain is he experiencing. Usually discogenic pains, particularly when you bend forward, if the pain aggravates, it's more of a discogenic pain which we assume. And back loading, extending your back and you having pain, is more of a posterior facet joint pain which we usually assume. And there are transitional symptoms, like you have pain when you sit, stand from a sitting position, or when you turn sides on the bed. These are transitional, that is instability sort of pains. So these are various pains which we usually encounter. Other than this, there is one most common myofascial pain, the pain related to your muscle weakness. There are some trigger points which form in the spine. All these are different sources of pain in the spine.
So in which of these conditions do you think PRP is useful?
So PRP has been studied in 2 major conditions. Now, first of all, to identify the source of pain is a very crucial thing in spine, which many papers or many people have missed when they write about these PRP injections, right? You use it in any case of back pain. You cannot consider all the back pains as same. You use it in a muscle weakness condition. You use it in a myofascial pain condition. It is not going to work. But the literature has 2 areas which were extensively studied. One is a discogenic back pain, where your disc is becoming harder, it is not able to take the load, and it is causing you pain. And the second is a herniation, or a slip disc, which people call, which is where your disc is not able to take load, so it slips out of its place. These are 2 conditions where it is used, and sometimes in the facet joint pains as well. These are 3 conditions where PRP have been used. But again, the literature is conflicting. One, because of the bias in selecting the patients, because of the bias in publication, because majority of the literature which comes are from the orthobiologic institutes, right, where they do these PRPs extensively. So usually the literature which come up from those institutes are likely to support the practices which they follow, right? So discogenic back pain, basically where there is supposed to be a minor inflammation inside. That is where they used PRP into the disc to reduce the inflammation. And there is some conflicting evidence that it can help in discogenic pains.
Okay. So, I mean, you brought up a very important point on medical research. So, a research methodology is very important. Not every paper written by a doctor or in the medical research is not accurate. If you know how to identify or how to compare a green apple with a green apple of a size and color, etc., only then you can get a proper idea of what actually we are treating. So, the problem with the research in PRP treatments is, unfortunately, the methodology has not been consistent, just like the lack of standardization in the usage of the PRP. So, that is very important to understand. And many of the papers, if you look at the conclusion, they say that it may be useful and you need more research. So, still it is under exploration, it is not a treatment of choice, right. So, in your shoulders, which conditions you think would be beneficial with the PRP?
Yeah, like you said, PRP is an area which is still under intense investigation. So we are talking about hardcore science. This is not social media. This is all hardcore research-based facts which we are talking. So when it comes to shoulder, the same biases, the same confusion, the same conflicts exist, and it is still under investigation. Even the US FDA has said that it is under investigation. It has not given a full approval for the shoulder. So there are, as in life, there is a big spectrum. We have a gray area, which is most of the area, and at one end we have a white area and we have a black area. So it is all, we know for sure that it does not work in mechanical conditions. So let me just invert your question. You asked me where it works. Let me start by saying it does not work in any mechanical problems. For example, it does not work in rotator cuff tears. It does not work in labral tears. Whenever there is a mechanical problem, whenever there is a structural damage, that will not be healed by PRP.
So here you are talking about rotator cuff tear. It is nothing but a cut in the muscle in the shoulder.
Correct, correct.
Same thing, the labral tear is cut in the lining of the cup of the shoulder joint.
Correct, absolutely. Right. So these are all basically soft
How about
tissue.
the frozen shoulder, which is very common?
Shoulders, frozen shoulders are also very common. I mean, in which there is no structural defect, but there is inflammation inside the shoulder joint. So again, the evidence is mixed. So there is some studies have shown, now we're talking about studies from across the world. There is like a landmark study, a state-of-the-art study from the US. There is a European guideline which has been issued by Mayo Clinic as well as from multiple centers across Switzerland. There have been studies in Australia. And then the consensus is that it is safe to do the PRP. There are not much side effects, so there is no harm in trying to explore where it works. So in adhesive capsulitis or frozen shoulder, there is some evidence that it can help. But again, so we are competing with already tried and tested established treatment methods for adhesive capsulitis. For example, we know physiotherapy works. There's no question about that. We know that in resistant cases, steroid works, which is much more economical and with much less side effects. So when we already have these problems which are already solved, we are trying to introduce a newer modality of treatment which is maybe helpful, but is it really a problem that needs to be solving is the question. So in adhesive capsulitis also a limited role.
So when we again go through the sieve, surgical sieve of shoulder conditions, the only area you can say the PRP may be useful is in frozen shoulder.
Frozen shoulder.
That too, you got to be really accurate in injecting the shoulder into the joint, right? If you're not accurately injecting into the joint, it may not work.
Exactly.
Because a stiff shoulder, your needle when you're passing it should be right in the joint.
That's where the
good chance that it can go anywhere around the shoulder.
Correct. So that's where the ultrasound guidance helps.
Useful. Right, that's about the shoulder.
Thank you.
Avinash, how about in hand and wrist? What conditions you would like to use the PRP?
PRP is used routinely for few of the conditions of hand, wrist and elbow. In the hand, it is commonly used in trigger finger and trigger thumb. In the wrist, it is used for decurvent stenosynovitis, carpal tunnel syndrome, maybe in some cases of TFCC injuries, literature has shown, papers have been written on these conditions. In the elbow, it is commonly used for lateral epicondylitis, that's the tennis elbow and the golfer's elbow. And few studies also have been done on biceps tendinitis. So all these conditions, there are literature.
The trigger finger or the decorients where you get pain around this part of your wrist, or the tennis elbow on the outer side of the elbow and golfers on the inner side of the elbow. All these are tendon issues. Among these tendon issues, any role at all in injecting the PRP?
Again, there is mixed consensus in the literature about the outcomes of tendinopathies,
Okay.
all these tendinopathies. So few say that it gives good results, few of the studies say it has mixed results, and few say that it's not useful.
Okay.
But none of the studies are high volume and long term studies.
Okay. So
I think of all the tendinopathies in the upper limb, one area where extensively it's been researched and there is some role compared to all other tendons is in the tennis elbow area. So which is also called as the lateral epicondylitis, where it is on the outer side of the elbow. In that one particular condition, there was, or in fact, might help to an extent in, especially in the chronic cases. Not an acute tennis elbow. Acute tennis elbow, we still try to do all conservative measures, physiotherapy, etc., some steroid injections. But in a chronic condition, there is a little, or there is some role compared to the other tendinopathies in tennis elbow.
Correct. The evidence is
Harshad.
the evidence is slightly more favorable when it comes to tennis elbow. I think it has a role in tennis elbows.
But the thing is, even though we say that there's evidence that the tennis elbow will get some benefit from PRP, it doesn't mean that that is the treatment of choice. Still, the treatment of the choice is you have to do the physiotherapy, you have to modify the activities, and you can take some splints to help. And the duration of how long do you use, don't expect that tennis elbow will go like that, right? It takes time. It may take around 2-3 months to see the benefit of all these. Even if you give a PRP, it is not going to be like a snapshot, it is going to go away. So it can still take.
That's the thing with all these conditions of musculoskeletal conditions. Role of PRP, it's not just the injection and then forget about it. So what all has been practiced before giving the PRP has to be done hand in hand along with the PRP injection. Only then there is some role. So you just can't give a PRP injection and say, yes, we have given and this is it and it is going to work. No, you still have to rehab that particular joint. You still have to do other conservative measures, and all the other protocols which have been already established for a particular condition have still has to be followed. Now, you can't have a blanket statement like saying, for example, in osteoarthritis knee, nowadays people say, oh, it's a substitute for surgery. No, you can't say that because surgery has a definitive role in advanced arthritis with deformity and with instability. You can't say a PRP is going to stop this from going ahead with surgery. That's what is coming into the general public more and more with this social media and the way it has been publicized and marketed. So that's one thing which we all needs to be aware of. Yes, there might be some role with minimal evidence, and we still need a robust standardization protocols which are not available as yet across the world, I must say. And also FDA, as Dr. Harsha was saying, FDA also hasn't still approved for approved for a PRP injection into osteoarthritis knee or in other conditions as well. We are just giving it because it is easier to give. That's all it is. And maybe some evidence, little bit of evidence, which we can always find for whatever we want to do. And it does have its side effects as well. Srinivas, what do you think? Do you think there's any side effects with giving PRP?
We do see patients who had injections into the knee, and they come with a proliferative synovitis. Yes. And I think you yourself have done debridement of another patient who came with a complication.
That's right. In joints like knee or shoulder, there is also we need to be careful. Any injection going into these areas, there is always like other injections, there's a risk of infection, and there is sometimes because we don't know what sort of leukocytes or the white cells are present in it. So it could be leukocyte poor or leukocyte rich. Sometimes if it is for reducing inflammation, we need a leukocyte poor PRP. So if you give a leukocyte-rich PRP, then it can actually proliferate more inflammation than reducing it, and that can cause a greater problem. A simple injection can lead to a massive problem like proliferative synovitis, for which you need even extensive surgery, 1 or 2 washouts, and that's a disaster. So we need to have a very standardized protocol and think before giving these PRPs.
Yeah, that brings us to one more important question. Who should be giving the PRP? Because we see a lot of orthopedicians are doing it, the rheumatologists are doing, pain specialists are doing, and even general physicians are also doing. So for me, it is important to come to a diagnosis, because we are here in orthopedics. We have so many subspecialties. The reason why we have come into subspecialty is we are not going to treat one orthopedic surgeon, general orthopod is not going to be treating everything. That is the reason why we are subspecialized, to improve the outcomes. To first of all come to a diagnosis, that needs a thorough assessment. So as a shoulder surgeon, what do you think? How do you come to a conclusion that the cause of this pain is this? What does it involve?
Correct. Very, very appropriate question. So basically, once you know the cause, treatment becomes easy.
Yeah.
So there are many ways to find out. Basically, the standard format that we all of us follow is speak to the patient, get a proper history, do a proper thorough clinical examination, find out whether it is a mechanical problem, whether it is an inflammatory problem, what sort of problem are we dealing with. And then you confirm that by some tests, X-rays, MRIs, CT scans, blood tests, all these will point us in the right direction. So based on our experience and based on our evidence that is current as of Jan 2025, then we see what is the benefit versus risk of the injection, and then we go ahead. We advise the patient that this may help you, this may not help you.
Yeah, I mean, when we were in UK, I think most of us returned from UK, and there was a standardization in practice. The standardization is, I see the patient, I come to a diagnosis, I'll do all the workup, I will identify the condition, and then the treatment. Am I able to treat the patient surgically or not? If not, if the patient has no indication for surgery, we do send the patient to a pain specialist. It is not that the pain specialist directly does the procedure, right? There was a way of doing it. Maybe that is the correct way, because not all pain specialists are trained in treating the knee problems, back problems, shoulder problems, hand problems. So I think that standardization is very important, and that may be one of the limitation of how the PRP has been used, and the results are very variable. What other limitations do you think in PRP?
Yeah, that's right. We need robust standardization protocols. Even the across the world, the consensus from rheumatologists world, from the osteoarthritis world, we still are trying to formulate. In every paper you see, the conclusion would be in even the randomized control trials or the meta-analysis, the ultimate conclusion is says that we still need to understand it a bit more. We need to understand the patient factors, and we need to have robust standardized protocols for usage of the PRP. That's what they say. So in spite of all the research, it's still that's where we stand now.
One more misconception which I would like to address. Now we have talked about some role of PRP in some conditions in various orthopedic problems, but I should stress this, that it doesn't mean that a PRP, like suppose you inject a PRP in the knee, your knee is not going to be a normal knee. The evidence doesn't support that a degenerated or a damaged knee is going to get back to normal. The evidence says that the pain can get better after this treatment. It's basically the pain which is troubling the patient, and that can get better, whatever small amount of evidence we have. But it doesn't mean that your arthritic knee is a normal knee again, or your back may get back to a normal spine again after the injection. That is a misconception which I think people should understand.
This is very rightly said. It is not actually regenerating any of these tissues. Even though we say a platelet-rich plasma is an orthobiologic, it is still not reproducing or regenerating normal tissues. I mean, we can look at all the research evidence. One of the good papers is in the spine. This is a simple example. This systematic review of all the research done in patients who had PRP injections for back pain has looked at 2,300 plus papers, and out of them only 11 papers were RCTs which were used in the study because it fills the criteria. Even in that 11 papers, the evidence is not conclusive. So I'm not a pessimist, and I would like to use a treatment which works for the patient. Unfortunately, because it is something which can be easily done, there is over commercialization of its usage, and we are giving false assurances to the patient that this is going to regenerate your tissues. I think as an educated lot who are in a professional level, we have to follow our ethics. Yes, have I not done the PRP? In my UK times, I have done the PRP. We studied how it works, and we know clearly, our conscience knows clearly that it doesn't work in most of the conditions. There may be some conditions, but that need to be again categorized or identify the patient and treat that particular patient, or use the PRP in that particular patient.
Particularly if you talk about PRP usage, it should not be promoted as the treatment of choice. It should be given as an option, explaining the pros, cons, the risks and the benefits, and being not the standard, still if the patient would like to try before taking a definitive option, yeah, it can be considered, but
it is not a
treatment of choice.
Treatment of choice, or it's not a substitute of a surgical treatment.
Correct. So adding to that, it is not a substitute for the rest of the established treatment as well. The patient will still need physiotherapy. The patient will still need to lose weight. When it comes to knees, the patient will still need to offload the knees by losing weight. Physiotherapy. All these things are as important as without PRP. So PRP is not substituting any of these.
Quick word about the role of PRP in around the foot and ankle pathologies. So the main areas are, we talk about ligament tears and again tendinopathies or degeneration around the tendons. So most commonly discussed areas are two areas mainly. One is in the Achilles tendinopathy. Once again, in acute stages we don't give it, so all the conservative measures have been tried, and in a chronic condition there is again injection, especially under ultrasound guidance, can be given, but again with a minimal role. Again in this area as well, there is no robust standardization with discussion with the patient and with little evidence can be tried, but again there is no strong evidence to show whether the bulk of the tendon is going to increase or it will come back to normal is again controversial. Again, the other area is a plantar fasciitis, so most of the plantar fasciitis treatment is conservative. 10% of these plantar fasciitis patients can go into a chronic condition where there's a pain in constantly. So initially, when the role of steroid to relieve acute pain is well documented, but in chronic conditions, yes, there is some evidence to show that it might work, but again, it has to be supplemented with physiotherapy and the footwear, etc., to counter that injection. So we still not sure whether it is actually the other modalities which has worked, or the actual injection itself has worked. And again, this area also requires a lot of other research and standardization protocols to give into these areas. And in acute tears, in ligament tears, when a sports person falls and injures their ligament, then there is no role. So for acute injuries, the PRP is not going to work for any of the ligament injuries.
Yeah, interestingly, recently I had one of our physicians who came, and he had an ankle sprain, and he was asking whether I can do a PRP. So unfortunately, even our doctor population also has no clear idea on actually it works or not. So that's the reason why we wanted to have this debate. And with the current evidence in the beginning of 2025, when we look at a proper research methodology done in all the studies, still there is lack of evidence that PRP is a treatment for any of the orthopedic conditions. It can be used as an investigative procedure, and the doctors who are using it as treatment has to definitely explain to the patients that it is more an investigative procedure with minimal complications, pretty much safe. However, that is not a substitute for definitive treatments. Thank you. Thank you all.
Thank you.
Right? Close.